Assalamu alaikum, everyone. My name is Rawad. I'm a third-year medical student. And to finish up our discussion on the brainstem, today we're going to be going over brainstem lesions. All right. So, inshallah, it's a continuation of what we discussed yesterday. So everything should make sense. I think the brainstem lesions are very, very easy if you know the brainstem anatomy well enough and you know the functions of all the cranial nerves. So inshallah, we shouldn't be having any problems with it today. Here are the objectives for today. As you can see, not too many objectives, and that's because we're going to spend quite a bit of time on every objective. First, we're going to talk about cranial nerve reflexes. It's just going to be a very quick summary. And then we're going to be going over every single cranial nerve and discussing what the lesion in that cranial nerve would look like, what would the presentation be. And then we're going to quickly discuss the blood supply of the brainstem. Okay, you guys have a lecture later on in the block about blood supply of the brain in general, so we're not going to go too deep, but just a few things that have very important clinical correlations. And finally, we're going to be discussing strokes or the actual brainstem lesions themselves, so the syndromes that you guys surely know by now. Okay, so very quick summary of the cranial nerve reflexes. Okay, these are all the cranial nerve reflexes that you guys are going to be seeing throughout the blocks. In order to answer the questions properly, you guys have to know which cranial nerves are in charge of which reflexes. So you guys know obviously by now that for each reflex you have an afferent arm and an efferent arm. So for example, if I were to touch, this is the example that everybody uses, the analogy, but if I were to touch a hot stove, for example, the efferent arm would be, of course, the sensory pathway, the spinothalamic pathway, and then the efferent arm would be obviously the anterior gray horn cells or the motor pathway. Okay, so I just want you to keep that idea in mind, that every single reflex has an afferent arm, something that senses the thing, and an efferent arm, something that actually performs this motor reflex. Okay, so for accommodation, if you guys remember from yesterday's session, accommodation, I talked about accommodation. Accommodation is basically when you're trying to fixate on an object, whether it be close to you or far away from you. You're going to talk about the specific mechanisms of accommodation in your next block. But for now, all I need you to know is that if I'm looking at something closer to me, my lens, the lens that's inside of my eyes, it's this little organ, it's going to basically change shape in order to basically adjust your eyesight to this object because it's very close to you. Okay, so that all has to do with the light rays and the whole convex concave, so it's going to become more convex in this example. Okay, so that's the accommodation reflex. Okay, the afferent limb would be your second cranial nerve, which is the optic cranial nerve, and that's because obviously it's in charge of sight and vision. So obviously if you're looking at an item or looking at an object that's very close to you, the afferent limb is going to be the optic nerve. And then the efferent, in this case, is going to be the oculomotor nerve. So remember yesterday we talked about how the oculomotor also has parasympathetic functions, and one of those was the lens accommodation. Well, this is an example of that. Okay, so the accommodation reflex, the efferent arm, is going to be under the control of the oculomotor nerve. All right. Next up is the corneal reflex. And the corneal reflex is very simple. It's basically just when something touches your eyeball or your cornea. Okay. Basically, you're going to be, as a reflex, you're going to be closing your eyes. Okay. Bilaterally. All right. So if somebody were to go ahead and touch my eyeball, I would close my eyes as a reflex. Okay. So obviously in this case, the afferent limb would be the nerve that's in charge of my sensation, the sensation of my face. In this case, obviously, it would be the trigeminal nerve, specifically the first branch, the ophthalmic branch of the trigeminal nerve. And then the efferent, the one that's in charge of basically the facial expressions and the facial muscles, would be the facial nerve in this case. Okay, and it says bilateral here, and that's because in the corneal reflex, when you want to close your eye in response to something that's maybe touching your cornea, you would close both eyes. Okay, so that's just a protective mechanism for us. Now, for the cough reflex, I talked about how yesterday we have the vagus nerve, which is in charge of both motor function of the pharynx and larynx and the soft palate, and also the sensory function. So in this case, the cough reflex, the afferent and efferent arm would both be the vagus nerve. All right, and for the gag reflex, okay, it's going to be the glossopharyngeal, the ninth cranial nerve, or the glossopharyngeal, which is the afferent limb, and then the vagus would be the efferent limb. All right, so it's a similar function. Now the jaw jerk. I'm not sure if you guys have taken this yet um, in your pro, but basically the jaw jerk is that when you want to, it's basically when you place a thumb or you place a finger on the jaw, and if you were to lightly tap it, then you would basically see the muscles of mastication sort of contract. In this case, both the afferent and the efferent arm would both be the trigeminal nerve, and that's because obviously you guys know the trigeminal nerve also supplies motor function to the muscles of mastication, as well as sensory function to the jaw area and the rest of the face. So obviously the afferent limb would be the sensory function or the sensory fibers from the maxillary in this case, or sorry, the mandibular, or the trigeminal, the third branch of the trigeminal. And also the efferent limb would also be the trigeminal, specifically the third branch. All right, lacrimation. Okay, lacrimation, again, it's the same reflex. Obviously, it's the tears. So in this case, the afferent limb would be the trigeminal nerve. All right, obviously, because that's your sensation and everything like that. So if something were to touch your eye, you would, as a reflex, you would lacrimate, you would produce tears. And the efferent limb, again, we mentioned this before, is the facial nerve, and that's because it supplies the what's it called? Sorry, it supplies the parasympathetic supply to both the lacrimal gland, and you guys know this as well, but the salivation specifically from the submandibular and sublingual. All right. Finally, we have the pupillary reflex. Now, this is the second parasympathetic function of the oculomotor nerve, if you guys remember from yesterday. The first one being the lens accommodation, the second one being the pupillary reflex. This is basically, as you guys know by now, if you were to enter a very bright room all of a sudden, then your pupils would basically constrict, and that's because obviously you want to limit the amount of light that's entering your eyes. Okay, so the one that's in charge of that is the oculomotor nerve, and again, the afferent limb, again, similarly to the accommodation reflex, would be the optic nerve. All right, so these are just your cranial nerves. That's everything that you guys are going to be talking about for the neuro block in terms of cranial nerve reflexes. So just keep an eye out for these keywords like the jaw jerk reflex, the accommodation reflex, all those things, because you might see them in your questions. And immediately you'll know, and you don't even have to memorize this table. If you just know the function of the cranial nerves, inshallah, it'll be enough for you guys to remember all these functions. Okay. Now, now we're going to go through every single cranial nerve in our brainstem, basically, and talk about a clinical correlation. In this case, it would be the nerve palsy. Okay, we're going to go through every single nerve, and inshallah, it's going to be super easy because it's as long as you know the functions of these nerves, you'll easily be able to know what the lesion would look like in this nerve. All right, so quick recap about the oculomotor nerve. It supplies all of the extraocular muscles except for two, which are the lateral rectus, which is supplied by the abducens, as you guys know, and the superior oblique, which is supplied by the trochlear nerve. All right, so obviously, if we know that the oculomotor nerve supplies all the extraocular muscles, we know that if we have a third nerve palsy or the oculomotor nerve palsy, then of course we'd have problems moving our eyeballs, and also we'd have a bunch of clinical correlations to the parasympathetic function as well. So the parasympathetic function of the oculomotor nerve, as you guys know by now, is the pupillary constriction and the lens accommodation. Okay, so obviously, if we're building up on that idea, if we have a problem in our oculomotor nerve, we're going to see ptosis. Ptosis, by the way, is when your eyelids would droop. Okay, mydriasis, or mydriasis basically is pupillary dilatation. As you guys can see here from this picture, this patient has pupil dilation, so it's a lot more dilated in this eye than it is in this eye. That's because obviously you lose the parasympathetic function of pupillary constriction. Lateral strabismus, and basically what lateral strabismus means is that your eye would be stuck in this sort of abducted basically, stage, because you can no longer, supply any of your extraocular muscles. So just as a reflex, your eye is going to be sort of, displaced in this direction laterally. All right. Okay, now a clinical picture, basically I copied, whenever you see clinical picture throughout the session, it basically just means I went through a few practice questions, specifically a few practice questions that talk about oculomotor nerve palsy, and I copied down what the clinical picture looks like. So a patient, you know, a patient shows up at the clinic with blah, 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 blah. That's what the clinical picture is. Okay. So in this case, what I found was the neurological examination reveals severe ptosis. Eye looks down and out, right side, fixed, dilated pupil. Okay. Fixed, dilated pupil, severe ptosis, and then the eye looks down and out. Basically the same thing that you see here. All right. This is what oculomotor nerve palsy looks like. All right. And again, this is a table from the first aid book. So again, you could skip the common causes for now, but this is what it would look like. So you would have absent pupillary reflex. Again, you would see all of these things. Motor outputs. Again, everything like that. So signs, ptosis, down and out gaze. All right. And again, this is just a picture to remind you where this lesion would be. So if you ever hear a case about somebody who has an oculomotor nerve palsy, you know that the problem is going to be in the midbrain specifically. And because obviously you guys remember, this is the oculomotor nucleus, all right, and it's exiting out of the midbrain right above this red nucleus. Do you guys remember that whole session from yesterday, right? So again, midbrain, you have the oculomotor nerve leaving from the midbrain, okay, through the interpeduncular fossa. You guys remember that? All right. Next nerve, the trochlear nerve, which is the fourth nerve. All right. So if you guys remember, the trochlear nerve only has one function, and this function is just a motor supply to the superior oblique muscle. All right. Now, superior oblique muscle, you guys remember, it basically is in charge of moving your eye inferiorly when it's abducted. Okay. So when your eye is abducted, the trochlear nerve is in charge of making it basically move down inferiorly. So that's how you're able to look down, for example, is because of the function of the trochlear nerve. So obviously then, if we build on that idea, if we have a fourth nerve palsy, it would cause diplopia, which is double vision, and weakness and depression of adducted eye. Okay? Again, weakness and depression of adducted eye, and that's because, again, the superior oblique muscle is in charge of basically moving your eye downward when it's adducted. All right. And again, the clinical picture is a 72-year-old male experiences difficulty in walking downstairs and reports some double vision as well. Okay. Walking downstairs is very, very important. Whenever you hear about a case of a person who's having trouble walking down the stairs or reading a book, for example, that's because they can't look down, then it's you'll know that it's a problem in the trochlear nerve. All right. And again, this is the table from first aid. So we can see obviously that we have the pupils higher in the affected eye. So this is what it's going to look like, right? And obviously that's because you can't, move the eye inferiorly when it's adducted. So it's going to look like this, okay? And again, just to remind you guys where the trochlear nerve is bleeding from, it is also the midbrain, slightly lower than the level of the oculomotor nerve. And if you guys remember this whole concept, it's the only nerve that comes out the posterior side of the brainstem. Okay, you guys remember this picture? Obviously, you have your crus cerebri, your lemniscuses, all of them right here, the cerebral aqueducts. All right, again, you'll know that you're at the level of the midbrain. Now, fifth nerve palsy, trigeminal. All right, so just thinking about this again, the trigeminal, let's start with the functions of it. Mostly, the trigeminal nerve provides sensory information or provides sensory input to all of basically sensation from the whole face and also motor function to the muscles of mastication. Okay, so if we have a problem in the trigeminal nerve, again, what would we see? The main thing we would see, of course, you'll know that the patient can no longer feel their face on the ipsilateral side of that lesion. Okay, and also the main thing that you want to note is that they would have ipsilateral jaw deviation. Okay, ipsilateral jaw deviation. And that's because these muscles are going to atrophy. At some point, these muscles are going to atrophy. So then the opposing muscles would sort of take over. Okay, and you would have ipsilateral deviation of the jaw. So if I have a problem, for example, in the left trigeminal nerve, then I'm going to have jaw deviation towards the left side, right? And this is the clinical picture following a viral infection. A 64-year-old man found that he had a hard time biting down, obviously because muscles of mastication are in charge of closing your jaw. on food, and the jaw was noted to deviate to one side. So this is a very, very classic picture of trigeminal nerve palsy. And this is again a table to, this table is taken from Dr. Yaqeen's slide. They're very, very helpful tables. So if you guys want to look through them at any point, please do so. There are specific functions. There's mastication. Okay, and what would the sign look like? Weakness of jaw, ipsilateral deviation of open jaw. All right. Sensation, we're going to skip the tympanic membrane thing because it's not quite important. And you can see here, even the sign is insignificant. Okay. Sensations. So obviously the sign would be facial hemi-anesthesia. Okay. You guys know what hemi means, right? Hemi just means half. So hemi-anesthesia means you cannot feel half of your face. All right. And again, the proprioceptive reflexes, this all has to do with the jaw. All right. And again, obviously you would also find, it doesn't mention it here or in this table, but you would have loss of the jaw jerk reflex. Okay. Remember we talked about the jaw jerk reflex right here. Okay. How both the afferent and the efferent arms are both from the trigeminal nerve. Obviously, if you have a trigeminal nerve palsy, you would also get diminished or loss of the jaw jerk reflex. Okay. Sixth nerve palsy, very similar to the trochlear nerve. We know that this nerve only has motor control of one muscle, which is the lateral rectus muscle, which is in charge of abducting the eyeball. Okay. By the way, some people face a little bit of confusion, all right, because we have different eyes, abducting them means different things. So for example, for the left eye, abducting the eye means looking to your left side. But for the right eye, abducting it means looking to the right side. So please watch out for that when you're reading your questions. If they mention you have also right-sided symptoms, whatever they may be in the face, and the patient has trouble looking to the right side, then you'll know that it's the right abducens nerve. Okay, so just something to look out for. Remember that abducting the eye means looking out. Okay, so again, since it controls the lateral rectus muscle, a palsy of the specific nerve would cause medial displacement of the affected eye. Okay, so since you can't look out or you can't abduct the eye, it's going to be displaced medially. As you can see from this child, he has medial displacement of this eye. Okay, displaced in the primary position of gaze, and the affected eye is unable to abduct. All right, here's what the clinical picture looks like. A 47-year-old female patient presents to her physician with a complaint of double vision when looking to the left, but not when looking to the right. Upon examination, it is found that her left eye does not move laterally. Okay, so they mentioned that she can't look to the left, and then they mentioned again that it's her left eye that's not moving laterally. So you know that it's the left abducens nerve. Okay, so this is exactly what I was talking about here. Okay, and again, just another diagram so you remember where the abducens nerve is coming out from. This is the caudal pons. Okay, so it's coming out right here from the pons, and you guys remember this is the facial nerve, sort of wrapping around the abducens nucleus. All right, this is the pons. Okay, just very quickly, since we already talked about all of the muscles, all of the nerves that supply the extraocular muscles, we're going to summarize them very, very quickly. This is very helpful because a lot of the questions that you get about brainstem, since they try to confuse you, are going to have ocular symptoms. Okay, and that's because 3 of these 10, I'm saying 10 because we don't talk about the first 2 nerves in the context of the brainstem. 3 out of those 10 nerves basically control the eye in some way. So you're going to get a lot of questions with ocular symptoms. So it's good to be able to differentiate which nerve is involved. Okay, so oculomotor, we're going to skip the parasympathetic functions of the oculomotor because it should be obvious at this point. But for the oculomotor nerve palsy, the signs are going to be ophthalmoplegia with the eye turned down and out. Okay, so if it's turned out, for example, if the eye is turned out, you'll know that the lateral rectus muscle is not involved. Okay, because if it was involved, you wouldn't be able to look out because you're not able to abduct the eye. Okay, and since it's turned down, it's the same thing. You'll know that it's not the superior oblique muscle. Okay, now for the trochlear nerve, again, superior oblique muscle, you're going to have weakness and depression of adducted eye. And the classic presentation would be a patient who cannot walk down the stairs or is having trouble walking down the stairs or reading a book. Okay, and finally, with the abducens, patient's going to have abductor paralysis and medial deviation of the eye. Okay, so again, medial deviation, abducens, cannot depress the adducted eye, trochlear, and then the eye turned down and out, oculomotor. Okay, and then again for oculomotor, you'll know that you'll have mydriasis and you'll have ptosis and all those things. Okay. Moving on to facial nerve, which is the seventh cranial nerve. Quickly, just talking about the functions very quickly. The facial nerve basically supplies all of the muscles of facial expression. So smiling, for example, closing your eyes, things like that. And also, one important thing that they love to ask about, it also has the motor function of the stapedius. Now, I don't want you to focus, or I don't want you to know too much about the stapedius because you'll take it in the next block. But stapedius is basically the small muscle in your ear that basically, when it's contracted, it's going to dampen sound. Okay, so it's it's an autonomic thing. But if there's a very, very loud sound near to you, then the facial nerve is going to work to contract the stapedius muscle. So it basically dampens the sound. Okay, I don't want you to know how specifically, you'll learn that later. So just know that it also has a function in dampening sound. Okay, so again, it controls muscle facial expression as well as lacrimation and salivation. So you guys know that by now for sure. And then it also has control over the stapedius muscle for dampening sound. Okay, you'll know by now, inshallah, you should know that facial nerve palsy is also called Bell's palsy. Okay, now you guys remember this whole concept about the lower motor neuron, for something very specific to the facial nerve. You'll remember yesterday we talked about how the facial nerve nucleus can basically be split into the upper half and the lower half. The upper half has bilateral input from both hemispheres of the brain, but the lower half only has the contralateral input. Okay, so for example, my left facial nucleus, the bottom half of my left facial nucleus is only supplied by my right hemisphere, okay, and vice versa. But the top half is supplied by both hemispheres. Okay, so here, if you have a cranial nerve palsy, that is the nerve itself and not the nucleus. Okay, if it's distal to the nucleus, then we're going to have ipsilateral Bell's palsy, and basically the entire half of the face is going to be affected. Okay, but if it's an upper motor neuron as opposed to a lower motor neuron lesion, then you're only going to have contralateral lower face palsy. Okay, we'll talk about that later on, inshallah. I'm going to have a diagram. So yeah, right here. So we're going to talk about it again. Okay, but again, for facial nerve, this is what the clinical picture looks like. Patient suffered from overexposure to cold, blah, 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 and when given a neurological test, had difficulty in closing the eye, so that's the motor function, displayed a loss of both the eye blink reflex and increased sensitivity to sounds, okay, because of loss of input to the stapedius muscle, okay? And had difficulty displaying his teeth, which is smiling, and chewing food, again, because he can't move the muscles of his face, especially on the side of the mouth. All right. In addition, his speech was somewhat slurred and he was unable to whistle upon request. Right. So facial nerve muscles, this is the clinical presentation. Okay. And again, I added the diagram here. So for facial expression, the sign you're going to have is facial paralysis, obviously, and the loss of the corneal reflex. For the stapedius input, you're going to have something called hyperacusis, which basically just means increased sensitivity to sounds. It says it right here. Or basically, you hear the sounds very, very loudly. All right, secretion, so you're going to have loss of lacrimation and dry mouth. Okay, and finally, taste, you're going to have loss of taste in the anterior third of the tongue, anterior 2/3. Okay. All right, moving on. And again, this is where it comes out from. You guys know by now, this is the pons. All right, now to quickly go over the idea of an upper motor neuron lesion for the facial nerve versus a lower motor neuron. So for the upper motor neuron lesion, okay, the lesion is going to be in the motor cortex. Okay, that's because, and again, it's a connection from motor cortex to the facial nucleus and the pons. And that's obviously because you guys know above the level of the facial nucleus, you'll have these corticobulbar. Remember we talked about this corticobulbar or corticonuclear tracts that are descending from your cerebral hemisphere. And the affected side is going to be contralateral. Okay, and again, this is why. So if we have a lesion right here, first of all, take a look at this nucleus. This rectangle here, the whole rectangle is the facial nucleus and is divided into two. You can see the upper half is receiving input from both cerebral hemispheres. Okay, so both ipsilateral, which is the dark blue here, because this is the left facial nucleus, and the green here for the right cerebral hemisphere. But the lower half is only receiving from the contralateral cerebral hemisphere. Okay, so that's why if you have an upper motor neuron lesion, then it's going to be the contralateral side that's going to be affected, and specifically only the lower muscles of facial expressions. Okay, and that's because there's obviously it's split into two, the upper half and the lower half. All right. For the lower motor neuron lesion, it's basically just the entirety of the supply of that nerve. So the facial nerve is going to supply the entire left side, for example, or the entire right side. So if you have a lower motor neuron lesion, then your entire left side or right side is going to be affected. Okay, so does that make sense? So in a question, you would get somebody who, for example, is unable to smile on his left side, but has no problem closing his left eye. You'll know that that's an upper motor neuron lesion. Or, for example, if it's a lower motor neuron lesion, then he cannot smile or close his eyes on the left side. Okay, so it's just something to think about. Moving on. Okay, we're going to skip vestibulocochlear, by the way. You'll see here that we skipped cranial nerve 8. And that's because you'll take that more in detail in your next block, but also it's vestibulocochlear. So it's vestibule and it's the cochlea. So if you have loss of the vestibulocochlear nerve, you're going to have vertigo, which is like dizziness, and also deafness. Then you'll talk about that in your next block. So the ninth nerve, which is your glossopharyngeal, okay? Thinking about its functions. Again, it carries sensory information from the posterior oral cavity and the posterior third of the tongue. Okay, and in this case, the sensory information would be both somatosensation, which means pain and temperature and everything like that, from the tongue, and also taste. It also contributes to salivation, and that's because obviously you guys know it supplies the parotid gland and provides motor function to the pharynx. Okay, so again, you'll notice back here in our reflexes, we mentioned how the gag reflex, the afferent arm, would be from the glossopharyngeal, and that's because it's providing sensory information from the posterior oral cavity. So that's the gag reflex. Okay, so obviously if you have ninth nerve palsy, you would have loss of the gag reflex, again, and dysphagia. Dysphagia basically means trouble swallowing, as well as diminished taste sensation. Okay, so the clinical picture is a 28-year-old woman comes to her family physician and complains of difficulty in swallowing. Okay, immediately it points at glossopharyngeal, but it doesn't exclude vagus. So at this point, you still have to be thinking it's either glossopharyngeal or vagus. And further examination reveals that she has no taste sensation of the posterior 1/3 of the tongue and lacks a secretion of the parotid gland. Okay, so basically cannot be clearer than this. It's very clear that this is the glossopharyngeal nerve. And again, the functions is to elevate the pharynx during swallowing. So what would that look like when you have a lesion? Dysphagia. Salivation. Again, it's insignificant, and that's because we have the facial nerve also supplying salivation. Taste, you're going to have loss of taste in tongue. General sensation, again, I don't want you to focus too much on this, but it's going to have loss of gag reflex, and also you're going to have anesthesia of the oral cavity, the posterior oral cavity. Okay. And again, you do have the baroreceptor reflex function of the glossopharyngeal nerve, but it's usually insignificant if it's a unilateral lesion. Okay, if it's bilateral, meaning both the left and the right glossopharyngeal nerves are in trouble, then this is going to be a little apparent. You're going to have loss of carotid sinus reflex. Okay, but it's pretty insignificant if you just have a unilateral lesion. All right, moving on to the vagus nerve. Oh, sorry, I forgot to add here, but the glossopharyngeal would be leaving out the medulla in this case. All right, I just couldn't find a cross section that would show the glossopharyngeal. So the vagus nerve, again, what does it do? Provides motor and sensory function to the muscles of the pharynx, larynx, and plates. Also has parasympathetic control over the thoraco-abdominal organs. You guys know this by now. The heart, gastric secretions, everything like that, under the control of the vagus nerve. Sorry. Okay, so the vagus nerve palsy causes dysphagia, which is similar to the glossopharyngeal. And that's because obviously it's also providing motor and sensory supply to the muscles of the pharynx, larynx, and palate. This is very similar to the glossopharyngeal. Hoarseness, and this is the most important thing, contralateral deviation of the uvula. Okay, you guys know the uvula, it's this little swinging thing that it's in the back of your oral cavity. So if you have a problem in your vagus nerve, you're going to have contralateral deviation. I misspelled contralateral, but contralateral deviation of the uvula. Okay, So what's the clinical picture looking like? An individual experienced the following constellation of symptoms following a brainstem lesion associated with a stroke of that region: hoarseness, difficulty in swallowing, diminished gastric secretions, and loss of some cardiovascular reflex functions. Okay, so pretty obviously vagus nerve. And again, this is the table. So the swallowing and vocalization. So you would have hoarseness. I mentioned that here. You'll have hoarseness and dysphagia and contralateral deviation of the uvula. Okay, you'll have hemianesthesia of the pharynx and larynx, and then also the loss of the cough reflex. Okay, so these are the main things that you're going to be having. Now, by the way, the reason that we're going through all of these cranial nerves in detail is because, as I mentioned before in the first session, yesterday's session, when you have a lesion in the brainstem, typically you're going to have involvement of more than one structure. So you're in your real practice, you're never going to come across a case of somebody with only a vagus nerve palsy only and no other symptoms. No, he's probably going to have 10th nerve palsy and also something else. Okay, so I'm telling you this so that later on in your questions, when you see, for example, a sign of a vagus nerve, you'll know that you're at the level of the medulla. And then based on that, you're going to also be able to guess, or not guess, but infer what other structures are going to be affected based on the region of that lesion. Okay. Okay. Moving on. 11th and 12th, I'm going to group them together. That's because their function is sort of simple. But the 11th cranial nerve, you guys know this by now, it just supplies the sternocleidomastoid and the trapezius muscle, okay, which is in charge of turning your head and shrugging. So an 11th nerve palsy leads to an inability to shrug or raise the shoulders or turn your head away from the affected side. Okay? So in this case, a 31-year-old man with a penetrating injury to the posterior triangle of the neck is unable to shrug his shoulder and turn the head to the opposite side. Okay? So turning your head away from the affected side, basically, if I have a lesion in my left accessory nerve, then I'm unable to turn and look to my right side. Okay, and then the 12th cranial nerve, which is hypoglossal, you guys know that it just supplies the muscles of the tongue. You're going to have tongue deviation towards the affected region. Okay, following a penetrated injury in the submandibular triangle, the tongue of a 45-year-old patient deviates to the left on protrusion. So which hypoglossal nerve? The left one. Okay. Okay, so this is very quickly, you guys should have noticed by now, but we have a lot of things that are deviating. You know, if something is deviating towards the left side or the right side, whether it's ipsilateral, contralateral. So this is what the table is for. So if you have a trigeminal lesion, then obviously we mentioned it's going to be your jaw that's going to deviate. And it's going to deviate towards the side of the lesion. If you have a 10th cranial nerve, then it's going to deviate away from the side of the lesion, and that's your uvula. Again, the vagus nerve. For the accessory nerve, you're going to have weakness turning head away from the side of the lesion. And then finally, for the hypoglossal nerve, the tongue is going to deviate towards the side of the lesion. Okay? And again, this is what the medulla at the stage would look like. This is the hypoglossal nerve taking input from the nucleus of the hypoglossal nerve, obviously. And then you have the vagus nerve receiving input from the nucleus ambiguous, which you guys should know this by now. It's your special visceral efferents fibers, okay, and that's because it's obviously supplying the muscles of the pharynx and the larynx, which are of branchial arch. They're coming from branchial arches or the pharyngeal arches, so that's why they're called special. Also, the dorsal nucleus of the vagus nerve, which is your GVE, your general visceral efferents, which are going to be for your gastric secretions, the heart rate, things like that. And then the NTS, the nucleus tractus solitarius. Okay, you guys know this by now. It's for taste. And finally, the spinal trigeminal nucleus, which is also going to be for sensation. Okay, this is what the hypoglossal palsy looks like. This is what the tongue deviation looks like. I just thought I'd show you. Okay. Now we're done from the cranial nerve palsies. By now, you guys should have a clear idea. When I tell you, for example, a facial nerve palsy, Bell's palsy, you'll know what that looks like, what that clinical picture looks like. All right, does anybody have any questions whatsoever about anything we've talked about so far, any of the cranial nerve palsies? Or should I move on? Okay, let's move on then. Now we're going to talk about the blood supply of the brainstem, very generally. We're not going to go too much into detail, but this is something called the circle of Willis. Okay, you'll learn about it more later on, inshallah. But it's basically just, it means basically what the circle of Willis is that it's a anastomosis between the posterior circulation of the brain or the nervous system in general, the central nervous system, and the anterior portion of the brain's blood supply. Okay, so this here, everything here would be the posterior circulation, and basically a continuation of this thing right here would be the anterior circulation. All right. So if you could imagine, let's imagine for a second that we take our picture of the brainstem and we attach it, we put it right behind this purple structure. Okay. And then we're able to tell which arteries supply which region of the brainstem. Okay. So again, this thing right here, this purple structure is this one right here. So you can imagine that your midbrain is over here, your pons is over here, and then your medulla is over here. Okay, so this right here is where the brainstem would be. Okay, and overlying it are all of these arteries. So starting from down here, we have these two things which are called your vertebral arteries. Okay, and they basically give off a branch right here in the middle called the anterior spinal artery. Your anterior spinal artery would supply the medial aspect of the medulla. Okay, as well as also a little bit from the vertebral arteries, but it's mostly coming from your ASA, your anterior spinal artery. Anterior spinal artery supplying the medial medulla. Okay, then they're going to basically join up here and they're going to form this big artery right here called the basilar artery. Now, the basilar artery, I mentioned that at the beginning of yesterday's session, but I told you that you have the basilar sulcus. I don't think see right here, this basilar sulcus. Basically, it's when the pons is sort of going like this, it's sort of caving in the middle. That's where your basilar artery would lie, okay? And it's giving off these branches called the pontine branches of the basilar artery. They're also supplying the medial aspect of your artery, of your pons, okay? Sorry, before I moved up to pons a little bit too quick, but down here in the medulla, you also have this artery. It's very, very important. It's called PICA, which stands for posterior inferior cerebellar artery. PICA is going to supply the lateral medulla. Okay, so if you think about what supplies the medial medulla, it's anterior spinal artery. What supplies the lateral medulla? It's the PICA, posterior inferior cerebellar artery. Okay, now the basilar artery, we know by now, it's going to supply the pons, the medial aspect of the pons. Okay, now the lateral aspect of the pons is going to be a little bit by these pontine branches and also from ICA, your anterior inferior cerebellar artery. Okay, so again, medulla, medially, it's ASA, anterior spinal artery. Laterally, it's PICA. For pons, medially, it's pontine and the pontine branches, and laterally, it's ICA, which is anterior inferior cerebellar artery. Okay, from the midbrain, if you can imagine, it's going to be like right here, right behind this structure. So the blood supply is going to be a little bit from the posterior cerebral artery, and also the last few centimeters of the basilar artery. Okay, so that's pretty much all of your the blood supply of your brainstem. All of the rest of the stuff, your anterior cerebral, middle cerebral, you guys don't have to focus on that right now. Just focus on these purple structures here. So again, one last time, vertebral arteries, okay, they join, and they basically give off this branch called the anterior spinal artery, supplying the medial medulla. Also, the vertebral arteries, each one is going to give off PICA, which is the posterior inferior cerebellar artery, supplying the lateral medulla. Okay, now the vertebral arteries they're gonna meet at the junction between the pons and the medulla, and they're gonna form the basilar artery, which is gonna run along the basilar sulcus of the pons. Okay, and this is gonna give off the pontine branches and the anterior inferior cerebellar artery. At the top is going to basically separate into the posterior cerebral arteries, okay, and the superior cerebellar. And mostly the blood supply of the midbrain is going to be from the posterior cerebellar, but also a little bit from the superior cerebellar. Or sorry, posterior cerebral, but also a little bit from the superior cerebellar. All right, so that's the blood supply of the brainstem. Okay, now our last objective, which is strokes. This is probably the heaviest one. So I need you guys to focus with me. And inshallah, if we're able to get through all of these strokes, or at least if you're able to follow along with me while we're talking about the cranial nerve palsies, then you should know all of these things very clearly. Okay, so starting from the medulla, we have our medullary syndromes. Okay, one thing that I want you to keep in mind when you're reading any question, and it's so important, I cannot stress how important it is your rule of fours. If you have your rule of fours memorized, and you know that your motor nuclei are going to be in the middle, and your sensory nuclei or sensory tracts are going to be lateral, then everything is going to make much more sense when you're reading your questions, when you're solving your questions. Okay, so starting from the medulla, specifically the medial medulla. Now, the anterior spinal artery supplies the medial medulla. We know this by now. Okay, this is what it looks like. It's going to be right here, the medulla. Okay, who can tell me what some of the structures that we have in the medial portion of the medulla are? We know that we have the pyramids. Okay, or again, in other words, your corticospinal tracts. You have your medial longitudinal fasciculus at the end of the corticospinal, or at the end of the medial lemniscus. So again, you have your pyramids, your medial lemniscus for your proprioceptive sensations from your body, your MLF, your medial longitudinal fasciculus, and the hypoglossal nucleus. These four things, they're going to be found in the medial aspect of the medulla. So obviously, if you have a lesion in this area, or if you have a stroke or a ischemia at the level of the anterior spinal artery, it's going to affect your medial medulla, and then you're going to have these following symptoms. So because of the involvement of the corticospinal tract, you're going to have contralateral hemiplegia of the body, okay, obviously. Because of the involvement of the medial lemniscus, you're going to have loss of contralateral proprioception. Because of the involvement of the hypoglossal nucleus, you're going to have ipsilateral tongue deviation. We mentioned that it's deviating towards the side of the lesion. And finally, if the medial longitudinal fasciculus is involved, I mentioned before, your MLF is in charge of coordinating your head movement with your eye movement. So then you're going to have nystagmus. Nystagmus is basically when you're looking at a patient who has nystagmus, if they're just looking straight ahead, their pupils, their eyes actually are going to be like vibrating, sort of like moving like this. So that's what nystagmus means. Okay, so this is the medial medullary syndrome caused by an infarct of either the anterior spinal artery or, in some cases, the vertebral arteries. It's going to also cause the medial medullary syndrome. Okay, simple enough. So you just have to think about it like this. I know that my corticospinal tracts are involved, so I'm going to have hemiplegia or paralysis of half the body. I know that my medial lemniscus is involved, so I'm going to have no proprioceptive function or no proprioceptive sensation from the body. Ipsilateral tongue deviation because of the hypoglossal nucleus involvement, and nystagmus for MLF. Okay, now moving on to the lateral medulla, we said before that it's under the supply of the pica. The pica artery is going to supply the lateral medulla, and again, if we start thinking about some of the structures that we have in the lateral medulla, we know that we have, for example, the nucleus ambiguus. Right here, nucleus ambiguus, which is in charge of, you know this by now, motor supply to the pharynx and the larynx. Okay, we have the sensory tracts, so the spinal trigeminal nucleus, and also the spinothalamic tract. All right, we have, it doesn't say it in this slide, but we also have descending sympathetic fibers. So just keep that in mind, sympathetic fibers. We have your vestibular nuclei, and finally we have inferior cerebellar peduncles. Remember when I told you guys that you have your peduncles exiting from each level? So in your medulla you have the inferior cerebellar peduncles, and then your pons you have middle and also superior, and then the midbrain you have the superior cerebellar peduncles. Well, in this case it's going to be the inferior cerebellar peduncles. Okay, so if we have an infarction or a lesion, or sorry, infarction of the I'm sorry, this is supposed to say pica, by the way. Infarcts of the pica. Okay, so just ignore this for now. It's supposed to say infarcts of the posterior inferior cerebellar artery causes lateral medullary syndrome, okay, which is characterized by dysphagia, again, because of the nucleus ambiguus, loss of pain and temperature from the contralateral face and, contralateral body and ipsilateral face. And that's because, you guys should know this by now, but your spinothalamic tracts for collecting pain and temperature from your body, it's going to cross over at the level of the spinal cord. Okay, so I think it was about 1 to 2 or 2 to 3 segments above where it enters the spinal cord is going to cross over. Okay, but your spinal trigeminal is going to cross over at your second order neurons, which are going to be all the way, at the specific site of the exit of the trigeminal nerve, where the second order neurons are. So they haven't crossed over yet. So at this point, you're going to get loss of pain and temperature from the contralateral body and ipsilateral face. Okay, so you'll know that this is your spinal trigeminal tract and your spinothalamic tracts in the lateral medulla. And finally, because of the involvement of sympathetic fibers or the descending sympathetic fibers, you're also going to have ipsilateral Horner syndrome. Do you guys remember what Horner syndrome was? The triad? Ptosis, meiosis, and hydrosis. Okay, basically ptosis, drooping of the eyelids. Meiosis basically means constriction of the pupils. And finally, anhidrosis basically means loss of sweats, basically from the face. And this is Horner syndrome. Okay. And finally, because of the vestibular nuclei, you also might have vertigo, which is just like dizziness. People, they can't keep their heads still because they're dizzy. And finally, you might have some ataxia or some cerebellar symptoms because of the involvement of the peduncles. All right, so those are your medullary syndromes. Let's review them very quickly. So this is what the medulla looks like. You'll see here the blood supply. Here, medially, you have your anterior spinal artery. And then also a little bit here, you have your vertebral artery. Back here, laterally, is your posterior, actually right here, sorry. Laterally is your posterior inferior cerebellar artery, pica. Okay, so you guys see here, for example, if we have involvement of the medial medulla, these would be where the corticospinal tracts are. This would be the medial meniscus, and right here would be the hypoglossal. Okay, so now it's starting, and this thing right here in the middle would be the MLF, the medial longitudinal fasciculus. Okay, so that explains the syndrome, the symptoms. And pica, obviously, you'd have your inferior cerebellar peduncles, vestibular nuclei, your nucleus ambiguus, and then your sensory tracts, the spinal trigeminal and the spinothalamic. Okay, again, forgot to mention, by the way, that the lateral medullary syndrome is also called the Wallenberg syndrome. So just remember that, Wallenberg. I don't think we were tested on the specific names, but it's just good to know. This is, again, a quick little refresher about the Wallenberg syndrome. Vertigo, vomiting, and nystagmus because of the involvement of the vestibular nuclei. Inferior cerebellar peduncle is what causes the ataxia and the dysmetria. Okay, so tremors. Reduced pain and temperature sensation from the contralateral side of the body, and then the ipsilateral face. You guys see the purple discoloration here. That's signifying loss of pain and temperature sensations. You're going to have hiccups, dysphagia, gag reflex, and hoarseness because of the involvement of the vagus nerve and also the nucleus ambiguus. And then Horner syndrome because of the involvement of these sympathetic fibers. Okay, and this is, again, a clearer picture of what it looks like. This is where all of these structures are, and this is the pica supplying the lateral medulla. Okay, and this is a table summarizing the medullary lesions. So pica, again, it's going to be the lateral medullary syndrome. This is a really good mnemonic. This is what I used last year to remember this lesion. Don't pick a lame horse that can't eat. So don't pick a pica. Lame for lateral medullary syndrome. Horse for hoarseness that can't eat because you have dysphagia, can't swallow. So these are the symptoms. And then for the medial medulla, you have the involvement of these structures, the corticospinal, the medial meniscus, the hypoglossal nerve. We talked about this already. And this is what it would cause the medial medullary syndromes. You're going to have paralysis, loss of proprioception, and then deviation of the tongue. And again, remember the rule of fours as much as you can. Okay, especially this one, especially the fact that the purely motor nuclei, which is the oculomotor, trochlear, abducens, and the hypoglossal, are in the medial aspect of the brainstem. Okay, so if you have a hypoglossal lesion, you'll know that it's medial medulla. If you have abducens, you'll know that it's medial pons. All right, and if you have oculomotor or trochlear, you'll know that it's medial midbrain. Okay, so just think about it like that. Moving on to the Pontine syndromes. Okay, there's I think 3 of these that you have to know. One of them isn't mentioned very explicitly in your slides, but I want you guys to remember it because we were asked about it quite a little bit. Again, as soon as you understand where the structures are, then you don't even need to be told what the specific syndrome is. You'll just be able to know based on the symptoms that the patient has. All right, so again, we know that this basilar artery is running along the basilar sulcus of the pons, so it's in the medial pons. The structures that are found in this region are the corticospinal tracts, the corticobulbar tracts. So these are upper motor neurons supplying the cranial nuclei that are below this level. So those would be the hypoglossal, the glossopharyngeal. All those things are going to be supplied by the corticobulbar tracts here in the pons. And finally, you have the abducens nucleus in the medial aspect, okay, as well as obviously the medial lemniscus, everything like that. All right, so what type of things are you going to have? Oh, first of all, now, the basilar artery, it's lying here in the middle, okay? We have the specific syndrome that's called locked-in syndrome. Okay, locked-in syndrome is caused by a few things, but the gist of the locked-in syndrome is bilateral, this is important, bilateral lesion in the medial pons. So usually if you have a lesion in the medial aspect of the midbrain, in the brainstem, it's either the right side or the left side. For locked-in syndrome, it's bilateral. So it's both the right medial pons and the left medial pons. Okay, so here, since you have involvement of both the right and the left side, and we know that the corticospinal tract is involved, you're going to have quadriplegia, which is just paralysis of the entire body. Not one specific side, it's going to be both sides. You're going to have loss of facial movement, except for your eye. Obviously, that's because you have your corticobulbar tracts in this case. All right, and except for eye movement, of course, because at the level of the oculomotor nerve, this is above the level of the pons, so you can move that. Except for the abducens. So since the abducens is also going to be affected, then you would only be able to move the eye vertically and not horizontally, because horizontal movement is under the control of the abducens nerve, as you guys know. And then finally, you're going to have bulbar palsy, which is just a fancy way of saying all the cranial nerves below this level, you're going to lose their function. So that's why you'll also get the aphasia, which is the same thing as saying dysphagia, loss of gag reflex, all those things. Okay, so this is locked-in syndrome. I believe we got a question in either our final or our midterm about locked-in syndrome, and specifically about the cause of locked-in syndrome. So I want you to just remember two main causes. First one is the occlusion of the basilar artery, and this is bilateral, so like both sides are lost. The basilar artery is just one, but I mean both sides of the pons are affected. Or something called central pontine myelinolysis. Okay, now what I want you to know about central pontine myelinolysis is basically when you're in a state of hyponatremia, and you suddenly get a very, a very rapid, very acute hyperosmolarity of the blood. And that's because of obviously sodium treatments. Basically, it's get sodium replacement when you have hyponatremia. If this happens too quick and there's too much of a rise in the osmolarity of the blood and of the extracellular fluid, then you're basically going to get loss of myelination of these neurons in the pons, and that's what would cause the locked-in syndrome. Okay, you don't have to focus too much on the pathophysiology of this syndrome of the central pontine myelinolysis because it's a little bit complicated, but it basically just would be because you have rapid onset of hypernatremia, which is a very quick switch from hyponatremia to hypernatremia. You would get efflux of all of the water outside of your brain, so all of the water would basically leave your central nervous system in order to, basically find a balance for the hyperosmolarity, and then you would get locked-in syndrome, the demyelination. Okay, so just remember these two causes of locked-in syndrome. Okay, all right. So again, we talked about locked-in syndrome. Now let's talk about ventral pontine syndrome, or another word for it is Miller-Gubler, and this is caused by ischemia of the branches of the basilar artery. Okay, so it's also the basilar artery with the branches of the basilar artery specifically. And the things that would be affected in this case would be the corticospinal tracts, the facial nerve, and the abducens nerve. Okay, so you guys can see here, there's a very great diagram because it shows you exactly where the site of the lesion is. You'll see what's involved here is the corticospinal tract and then the abducens nerve, and also the facial nerve. So obviously, what would you get? You would get contralateral hemiparesis, ipsilateral facial weakness, and because again, this is affecting the facial nerve and not the facial nucleus. Okay, so that makes sense. And ipsilateral lateral gaze palsy. That's because of the involvement of the the abducens nerve. Okay, I want you to remember one thing. Here, it's the involvement of the facial nerve. Okay, if I ever see that the facial nucleus is involved, then it's going to pretty much always be the anterior and inferior cerebellar artery, the ICA artery that's in charge. We'll talk about that in the very next slide. Okay, so again, this is what it looks like. This is where the subtle lesion is. You're going to have corticospinal tract involvement, abducens, and the facial nerve involvement. Okay. Now, Raymond syndrome, very, very quickly. Basically, it's the same clinical manifestation of Miller-Gubler, except for the facial nerve involvement. Just remember this, okay? Just remember that in this case, for Miller-Gubler, you have involvement of both the facial nerve and the abducens. But here in the Raymond syndrome, it's only the abducens that's involved, okay? And also the corticospinal tract. All right, the lateral pontine syndrome, which is called the ICA syndrome. So this is similar to the Pica syndrome, which is caused by, obviously, the Pica artery. Here you would have lateral pontine syndrome caused by an infarction of the anterior inferior cerebellar artery. So we could start to think about this, similarly to how we thought about the lateral medullary syndrome. So we know that there's going to be our sensory tracts there, so spinothalamic and the spinal trigeminal. We know that the facial nucleus is going to be involved since it's a little bit more lateral, okay, than the abducens. The vestibular nucleus is also involved, and then you have your cerebellar peduncles. Okay, so because of the spinothalamic tract, you're going to have contralateral loss of pain and temperature from the body. The spinal trigeminal, ipsilateral loss of pain and temperature sensation from the face. The facial nucleus obviously will have ipsilateral facial paralysis. The vestibular nuclei, so then you're going to have vertigo, and then the cerebellar peduncles, you're going to have the cerebellar symptoms that are ataxia, dysmetria, things like that. Okay. All right. So again, this is a quick little summary of the pontine syndromes. So basilar artery locked-in syndrome, you're going to have quadriplegia, loss of horizontal eye movement, and then also loss of voluntary facial movement, including mouth, tongue, everything like that. Okay, and it's caused by, actually it doesn't mention what it's caused by, but the structures involved are the pons medulla and the lower midbrain. Corticospinal and corticobulbar are involved. Ocular cranial nerve nuclei, and then the paramedian pontine reticular formation. So the reticular formation is in charge of your consciousness. If this is spared, then your consciousness is preserved. So just should know this. And then your anterior inferior cerebellar artery, your lateral pontine syndrome. What's going to be involved is the facial nerve nucleus. So then you're going to have paralysis of the face. Vestibular nucleus, so then you're going to have vertigo and nystagmus. The spinothalamic tract, so you're going to have pain of temperature sensation from the contralateral body and the ipsilateral face. You're also going to have the Horner syndrome, which is similar to what we saw in the lateral medullary syndrome. And then you're also going to have ataxia and dysmetria because of the involvement of the cerebellar peduncles. And then finally, you're also going to have, this thing, but it's not that important, the ipsilateral sensory neural deafness. Okay, so just remember these. All right, so now you're starting to see a pattern. Okay, we know that if it's medial, a lot of the times we're going to see involvement of the corticospinal tracts. If it's lateral, a lot of the times we're going to see involvement of the spinal trigeminal or the spinothalamic. Okay, so then you pair that with whatever cranial nerve is involved. So, for example, if you have contralateral paralysis of the body and hypoglossal nerve or like tongue deviation, medulla, medial medulla. Okay, loss of pain and temperature from the contralateral body, and also dysphagia and things like that. Lateral medulla. Okay. Medial pons, corticospinal, you're going to have, hemiparesis, and also abducens, then you'll know you're at the medial pons, and same thing. For the lateral pons, you'll see the facial nerve nucleus and also some spinothalamic tracts and spinal trigeminal nucleus involvement. You'll know that you're at the lateral pons. Okay, so it's very easy so far, inshallah. All right, going up to the midbrain. we have just two, I think it's just two. Yeah, just two that we need to know for the midbrain. The Weber's syndrome and the Benedict syndrome. Those are what's in your slides right now. The Weber syndrome is caused by a lesion in the medial cerebral peduncle in the midbrain. So this is where it would be. So this is a picture, and this is Weber's syndrome, all of this right here. So what's involved, we can see that it's the corticospinal tracts and the crus cerebri, because again, you're in the midbrain now. So this is, just to orient ourselves, this is the substantia nigra. This is the crus cerebri, which has the corticospinal and then the corticobulbar pathways and all those things. This is the oculomotor, and then this is the red nucleus in the center. This thing, the red nucleus. So for Weber syndrome, there's involvement of the oculomotor nerve. There's the involvement of the corticospinal tracts, and you also have involvement of the corticobulbar pathway. So then you're going to see the contralateral hemiplegia of the lower face. Okay, and again, this is the same concept that we talked about back. Was it here or was it here? Right here. This is the same concept. Okay, if it's an upper motor neuron lesion, you're going to have loss of the contralateral lower face muscles. Okay, it's the same concept here. So since we have the corticobulbar tracts involved here, you're going to have contralateral hemiplegia of the lower face. Okay, so again, contralateral hemiplegia of the body, contralateral hemiplegia of the lower face, and then the oculomotor nerve palsy. This is Weber syndrome. Okay, Benedict is basically just right here. So there's no involvement of the crus cerebri, but there is involvement of the red nucleus and the oculomotor nerve. So all you're going to see is the oculomotor nerve palsy, which we know by now. You're going to have ptosis. You're going to have basically your eye is going to be displaced down and out. And also here for Benedict syndrome, since you have involvement of the red nucleus, you're going to have some cerebellar symptoms that are contralateral tremor and ataxia because of the involvement of the red nucleus. All right, so these are all of the syndromes that you guys went through in your lecture. Just a very quick recap of all the syndromes. I don't want you to memorize them. I just want you to think of basically just find your own way of solving these questions, okay? So for medullary syndromes, you have to know whether it's medial or lateral. So for medial structures, we know that we have the corticospinal tracts, we have the medial lemniscus, we have the hypoglossal nerve, and then also the MLF. Okay, for lateral medulla, we know that we have the spinothalamic and the spinal trigeminal. We know that we have the nucleus ambiguus, the vestibular nuclei, and then sympathetic fibers. So all of these structures are going to be involved, are going to be affected if you have the lateral medullary syndrome. And then which arteries? It could be, for medulla, it could be the anterior spinal if it's medial, vertebral arteries, also if it's medial, or pica if it's lateral. Okay, for pontine, if it's medial, you'll know that there's involvement of corticospinal and corticobulbar pathways and the abducens nucleus and nerve. If it's lateral, then you'll see the facial nucleus, you'll see the spinal trigeminal tracts, cerebellar peduncles, and vestibular nuclei, so similarly to the lateral medulla. And then the arteries are the basilar arteries, and then the pontine branches of the basilar arteries, and finally ICA, which is anterior inferior cerebellar artery. This one's specific, it's very specific to involvement of the facial nucleus. Okay. And finally, mesencephalic syndromes, which just means midbrain. There's oculomotor involvement. A lot of the times there's going to be corticospinal tracts and corticobulbar involvement, the red nucleus, and a lot of the times going to be also the trochlear nerve involvement, okay? And the arteries are going to be, again, like I mentioned, the basilar artery and the posterior cerebral artery. And then there's also the superior cerebellar artery, okay? But again, it's not that important. Okay. Now, this is it. Now we're going to just do some questions. But I want to point out the fact that for brainstem specifically, for brainstem lesions specifically, there's basically two types of questions that you're going to get. Two types for the most part. You might get some other ones, but for the most part, these are the two types of questions that you're going to come across. Either you're going to have a clinical presentation, and then you're going to be asked which cranial nerve is this or is involved, or you're going to be given a clinical presentation and you're going to be told which region of the midbrain is involved. Okay, those are the two most common types of questions. That's why I'm telling you, like, as long as you just understand that, for example, the hypoglossal is coming at the medulla, the abducens is coming at the pons, then you're able to piece everything together. You're going to be able to solve these questions very easily, inshallah. Okay, so I'm gonna ask you guys a few questions. Please type your your answers down in the chats, please. Okay. First question. A 10-year-old boy has right arm and leg dystaxia, nystagmus, hoarseness, along with meiosis and ptosis on the right. Bronchoscopy reveals a paretic vocal cord on the right. The lesion site is responsible is most likely the, who can tell me? Is it A, dorsolateral medulla, B, dorsolateral pons, C, internal capsule, D, left red nucleus, and E, right dorsal motor nucleus of the vagus nerve? Who can tell me? Okay, I have an E. All right, so the answer is actually A. So this is, guys, if you remember, this is the lateral medullary syndrome, okay? Right arm and leg dystaxia basically just means tremors. This is because of involvement of the inferior cerebellar peduncles. Remember, we talked about right here, we talked about you're going to have involvement of the cerebellar peduncles. That's why you're going to get the dystaxia, all right? Nystagmus, hoarseness, obviously because of the nucleus ambiguous, all right? Now, the dorsal motor nucleus of the vagus nerve, this is more for this is a general visceral efferents fibers. These are for the thoraco-abdominal organs, okay? They're providing parasympathetic supply to the thoraco-abdominal organs, okay? But if it's specific to like hoarseness and things like that, then it's the nucleus ambiguous, all right? Which are special visceral efferents. And then the meiosis and ptosis is because of the Horner syndrome, the ipsilateral Horner syndrome. All right. And again, the vocal cord because of the involvement of the vagus nerve. Does it make sense? Does it make sense why it's not E? E would be basically for the thoraco-abdominal organs. So if you have a patient with diminished gastric secretions, then it might be E. But in this case, you have dystaxia because of the cerebellar peduncles, nystagmus and hoarseness, or sorry, nystagmus because of the vestibular nuclei, hoarseness because of the nucleus ambiguous, and meiosis and ptosis because of the sympathetic fibers, the descending sympathetic fibers. So this is dorsolateral medulla. Right. All right. So, second question. A 24-year-old male was hiking in the Rockies on a winter day and became lost. He was discovered a day later and was admitted to a local hospital for a precautionary examination. The patient suffered from overexposure to the cold, and when given a neurological test, had difficulty in closing the eye, displays the loss of both the eye blink reflex and increased sensitivity to sounds, and had difficulty displaying his teeth and chewing food, especially on the side of the mouth. In addition, his speech was somewhat slurred, and he was unable to whistle upon request, which the cranial nerves is involved. Who can tell me? So this one is basically two questions in one. It's testing whether or not you know what the clinical presentation would look like, and it's testing your knowledge of the anatomy of the brainstem. So perfect. Yes, it is E, which is the facial nerve. Exactly. So the facial nucleus wrapping around the abducens. This is the facial nerve. Again, it's providing motor supply to the muscles of the face. So that's why you're going to have difficulty closing the eye. That's why you're going to have loss of the blinking reflex. And it's also innervating the stapedius muscle. So that's why you have the hyperacusis, which is the increased sensitivity to sounds. Okay? Perfect. Perfect. So inshallah, yeah, it's going to be easy for you guys, inshallah. All right. An elderly female suffering from an infection complained that she could not salivate and was unable to display lacrimation on the right side of the face. Following a neurological examination, it was determined that a peripheral component of a cranial nerve was affected by this disorder. Which of the following cell bodies of origin form the origin of the affected cranial nerve? So, could not salivate and unable to lacrimate. So, no lacrimation, no salivation. Which one is this? Any guesses? No. So I got a C. It's not C, it's actually D. So inferior salivatory nucleus is actually from the glossopharyngeal, and that's for the glossopharyngeal, and that's for the salivation from the parotid gland. Okay, so if it's parotid gland, then it would be C. But since we have loss of lacrimation and salivation, that's telling you that this is the facial nerve. And the facial nerve, you guys remember from back here, facial nerve, secretion from the superior salivatory nucleus, and also, secretion and also lacrimation from the superior salivatory nucleus. Okay? So lacrimal and then the submandibular and sublingual glands, both of them are going to be under the control of the facial nerve through the superior salivatory nucleus. Okay? But that's a good guess, though. See. All right. And I think this is our second to last question, maybe. Which of the following structures was affected by the lesion at B? If we have a lesion here. First of all, what level of the brainstem are we looking at? What level is this? No, this is the pons. So you guys know that it's the pons because first of all, we see these little horizontal lines at the front here, and this is your basilar pons. And also we have the fourth ventricle in the back here. And since we have the fourth ventricle, we know that we're at the level of the pons. So what structure is affected by this lesion at B? It's medial and it's anterior. So what would this be? All right, so the answer is actually corticospinal tracts. All right, so if you guys remember, if we go through our pons cross sections, I think I can go through one of them maybe from our older sessions. Hold on. Our older sessions. Yeah. Okay, for pons, sorry, let me. Okay. For pons, you guys remember. Okay, this first of all, we know that we're at the pons because we see this fourth ventricle. But all of these things here in the basilar pons are the corticospinal and corticonuclear fibers. Now, posterior to the basilar pons, which is this section here, that's where you'll find the medial lemniscus. All right, so if we're looking at this section right here, then it's the corticospinal tracts. But if we're looking posterior to that, then it would be the medial lemniscus. All right. Sorry. So again, corticospinal, because the medial lemniscus and also the medial longitudinal fasciculus would be all the way here in the back. This is where it would be. Okay, but since we're looking at the basilar pons, these are your corticospinal tracts. Okay. Finally, I think this is finally, yeah. Emma is a 64-year-old woman who has had heart disease for many years. While carrying chemicals down the stairs of the dry cleaning shop where she works, she suddenly lost control of her right arm and leg, right leg and arm. She fell down the stairs and was able to stand up with some assistance from a coworker. When attempting to walk on her own, she had a very unsteady gait with a tendency to fall to the right side. Her supervisor asked if she was all right and noticed that her speech was very slurred when she tried to answer. He called an ambulance to take her to the nearest hospital. Upon admission, her face appears symmetric, but when asked to protrude her tongue, it deviates towards the left. Okay. She is unable to tell if her right toe is moved up or down by the physician when she closes her eyes, and she cannot feel the buzz of a tuning fork on her right arm and leg. In addition, her right arm and leg are markedly weak. The physician can find no other abnormalities in the remainder of Emma's general medical examination. So where in the nervous system did this damage happen? Which a lot of you guys already answered. Yes, it is E, left medial medulla. Okay, so how do we know it's left medial medulla? First of all, if we think about the medial medulla, what is there? The corticospinal tracts, the medial lemniscus, and also the hypoglossal, and also MLF. Okay, so corticospinal tracts, she has, where is it? Right arm and leg are markedly weak. So contralateral hemiparesis. So that's why her right arm and leg are also very weak. And also contralateral loss of proprioception. So that's why she's unable to tell if her right toe is moved up or down by the physician when she closes her eyes, and she cannot feel the buzz of a tuning fork on her right arm and leg. This is the loss of contralateral proprioception. And finally, because of the hypoglossal nerve involvement, we have ipsilateral deviation of the tongue. So tendency, protrude her tongue and deviates towards the left. Okay, so towards the left. So that's how we know that the lesion is on the left medial medulla. All right. So thank you all so much for watching the session. I hope that it's going to be a good recap for you, inshallah. I tried to keep it as short as possible. So, before your final, you could just, if you don't have enough time to maybe review the entirety of the Brainstem lectures, you can always just come back here to watch this session. Inshallah, I kept it short for you guys. And my information is down here if you guys need to know. Actually, my number is not down here, but you can find it in the other session. So you're able to, contact me at any time of the day to let me know if you have any questions. Okay, here's the QR code. Please let me know what you think of this session, and thank you all so much.